I want to reintroduce Dr. Jay Natarajan. He's a integrated vascular surgery resident at the University of South Florida. So Dr. Natarajan, the floor is yours.
Good evening, everyone. My name is Jay Natarajan, and I'm a resident at USF Vascular Surgery. I'll be presenting a case of sequential infrainguinal bypass for limb salvage in a patient with advanced critical limb ischemia. So this is the case of a 66-year-old male with a past medical history of COPD, former smoker, prior DVT history, hyperlipidemia, and peripheral artery disease. And his surgical history includes a prior rotator cuff repair and revascularization just to the left lower extremity, which I'll further illustrate. He's otherwise an active and ambulatory gentleman, and he participates in labor-intensive woodworking and construction. So his revascularizations begin with a left SFA to a PT in situ vein bypass for rest pain back in 2018. About 6 months later, the patient presented to UF Shands with an occluded bypass and hallux gangrene. There he underwent a left SFA to PT bypass with contralateral non-reversed GSV, and he underwent debridement of his toe wound as well. He was discharged on aspirin and Plavix, and he was able to heal his toe wound and avoid amputation. Unfortunately, that bypass underwent multiple interventions, and despite these attempts at salvage, it occluded about 4 months later in June of 2019. Subsequently, a left SFA to proximal AT bypass was created with PTFE, and a Linton patch was created with a segment of basilic vein as well. 2 months later in August, the patient presented to Shands with a graft infection and dehiscence of his incisions. And while there was no evidence of frank purulence in the operating room, he underwent multiple washouts with antibiotic bead placement. And ultimately, since the bypass was patent, the graft was kept in place and the patient was started on antibiotics. He currently remains on lifelong suppressive cefadroxil, but again, he was able to heal the incisions properly following this intervention. So over this follow-up period, the patient ended up moving to Tampa and continued vascular surgery follow-up here at Tampa General. And during this course, he developed malperforans ulcers and underwent amputation and was able to appropriately heal those amputation sites. So from 2023 to 2024, he had multiple clinic follow-ups and surveillance duplexes, and the bypass waveforms were multiphasic and without any significant velocity changes. So he was just monitored on aspirin and at this point Xarelto therapy. Unfortunately, he presented to clinic in September 2024 with decreased sensation to his left foot and worsening pain ongoing for 1 week. And the bypass duplex demonstrated a thrombosed bypass. So he was diagnosed with Rutherford 2A acute limb ischemia and underwent thrombectomy and thrombolysis as well. So this angiogram from that acute limb event demonstrated occlusion of the SFA to AT prosthetic bypass. And after cannulation of the bypass, he was heparinized, and a penumbra bolt catheter was used to thrombectomize the graft too. So there was some spasm in the anterior tibial artery, and the collaterals from the AT ended up filling the foot. So a unifused lysis catheter was left, and the patient was brought back to the operating room in 24 hours. On the takeback, the bypass now appeared patent, but the AT distal to the bypass appeared somewhat occluded. So the lesion was crossed with a combination of crossing catheters, and it was ballooned. And with moderate improvement, TPA was dripped to this area of concern, and repeat angiography appeared much improved. So there was pedal outflow, and the intervention was stopped. And the AT ended up having a triphasic signal at case completion as well. So after this acute ischemic event, the patient had 2 clinic follow-ups and arterial studies with Dr. Anatakis. And at both times, he was noted to have multiphasic waveforms of the bypass. However, at the second visit, he was noted to have a monophasic AT on duplex and exam. So given that he was asymptomatic with these changes, this prompts the question, would this change in outflow prompt empiric intervention? And I'll provide a little more information here too. So we ended up taking the patient for an angiogram just to plan for definitive outflow treatment. So here we see patent proximal bypass segment followed by tibial outflow via the AT, and this eventually collateralizes to the PT to fill the foot. And at this time, we had optimized the bypass inflow and treated the stenosis at that proximal anastomosis, and a drug-coated balloon was inflated here. But following treatment, there was a fistula with the common femoral vein, and given that we didn't want any flow compromised through the graft, we treated this segment with a Viabon-covered stent, and the flow was much improved, as seen on this image here. So at this time, I'd like to pose the question. So if you were to optimize the outflow for this patient, one, would you again empirically treat this patient just based on the change in the waveforms of the anterior tibial artery? Secondly, would you come off of the native AT, or would you come off of the PTFE bypass? I guess additionally, how would you reach the distal target? And along with this, what would be your tunneling strategy? And as well as what conduit would you use? Because given his prior interventions, he doesn't have any GSV as well.
All really compelling questions. So, Dr. Patel, is anybody willing to answer or offer sort of their strategy given the presentation? We're obviously in tertiary sort of remedial strategies for distal revascularization. So probably
Yeah.
just about any solution could be offered.
So current comment would be conduit, potentially using arm vein. While people are typing, and you may not know this since it was kind of two different institutes, but your original bypass, do you know what the size of your greater saphenous vein was?
I am not sure because I didn't have all of the imaging information from the other institution. So I'm unsure exactly how large the GSV was at that time.
Yeah, no, I think you pose great questions, and this is something that we all see in our practice, and they're very challenging cases. And so, my algorithm is, again, do you chase a change in waveform? I'm less likely probably to do an ABI on patients with tibial bypasses. So I do have a lower threshold, whether that is a lower surveillance duplex within 3 months, depending on your peak systolic velocities and inflow and outflow. But I agree with somebody that is getting to the point of heroic efforts. I want to be a little bit more aggressive. And then Dean says that he thinks the GSE was marginal, hence early bypass failure. And so I'll let you kind of proceed, and then definitely have multiple more questions for you.
Sure. So for the final intervention, we had chosen to optimize the outflow with an AT to PT jump bypass. So the left cephalic vein was harvested, given that the basilic was used for a prior patch, and that vein underwent valvulotomy and was tunneled in the subcutaneous plane and was anastomosed. The patient ended up healing his incisions, and he had a normal postoperative course. And he was seen in January with a patent bypass and normal velocities on duplex. He continues to remain without any evidence of chronic limb-threatening ischemia and has been able to ambulate and continue woodworking. And he's still on Plavix, Xarelto, and that suppressive antibiotics regimen as well. So happy to take any questions at this time. And thanks to FES for the opportunity to present, and Dr. Arnatakis for his continued mentorship.
Thank you for that. That was a really great presentation. And the introduction, well, it has so many layers to it, right? There's early vein bypass failure, and then redo bypass. It's the remediation of that. And now you're sort of in that tertiary quaternary decision-making algorithm. You're still going to the mat for this patient. And now you've sort of had to come up with these, like you very astutely said, there are a lot of different choices. Do you throw in the towel and give the guy an amp finally? Do you go and just remediate the bypass and just do an interposition graft that goes to a more distal target or an alternative outflow target based on your angio? Do you jump like you did? And if you do jump, now are you using a piece of plastic? Are you using autogenous vein? Are you going to use cadaveric vein? So a lot of different things. Certainly composite sequential bypasses have been around since the early 70s. That was when they first were on the scene, and it was very in vogue in the 80s and up until the mid 90s. It often fell out of favor thereafter when heparin bonded PTFE and most of the vein sort of the Linton-Neville vein patch became a little bit more in vogue. But it's still something to think about. And obviously for this patient, it's worked reasonably well. I'll leave it open to the floor. As Dr. Patel, has anybody sort of offered additional questions on the QA?
Yeah, so I'll get to the questions. Um, so I like in situ bypasses. I will tell you that, and Sal, was that your case, or not? I don't know.
I took care of the patient at some point in time while at UF. I don't believe
So
it my primary.
so the Prevent 3 trial looked at in situ bypasses versus reverse greater saphenous vein. And I like in situ myself because it maintains the vasovasorum, it minimizes myointimal hyperplasia. The tricky part for in situ bypasses, and I would love to hear if anybody does it, how they handle it. So a lot of times you're sewing onto really the proximal SFA, and as we know, a lot of times these are either occluded or severely diseased. So you may ultimately do some type of endarterectomy there, or you may be blindly passing hemostats just to get improved inflow. The other challenge I think with in situ bypasses is after I do the proximal and distal anastomoses, I take an ultrasound and then mark out where these large branches are, and then I do kind of small skip incisions, and then just clip them or tie them off. But I do see, and I don't do post-operative or intraoperative angiograms, which some people may do completion angiograms, and it's probably more important to do that for in situ bypasses, just so you're not missing any saphenous vein branches that ultimately can be the reason your grafts fail early, because I do see sometimes these branches steal, and then distally the vein kind of goes out. And then in addition to that, the Prevent 3 trial looked at vein sizes less than 3.5 millimeters did worse in situ compared to obviously larger sizes. But so that was just my comment. If anybody does in situ, I'd love how they handle the branches. Dr. Fieser asked, someone quoted about a 25% 12-month primary patency for redo bypasses. Do we know if that still holds true?
Sorry, patency for the initial bypass that he had.
The primary for a redo bypass.
Oh, gotcha. Um, Asking if that's still true. I believe that it's possible. I mean, I see patients with here at TGH, we see patients with multiple redo bypasses, and I think 25% seems about appropriate for like primary patency without any sort of like secondary procedure, but would believe that that's somewhat higher after undergoing some sort of secondary procedure to keep it patent.
It's certainly that literature has been out there for salvage of a vein graft or young vein grafts, so less than a year, that undergo thrombolysis with salvage, and are on secondary patency. Their salvage is poor at a year. Certainly, that's the 1 out of 4. A full redo bypass, if you haven't, and that's the challenge with the surgical literature, particularly in the bypass literature, with all of these trials that even with BEST and even with Prevent 3, it's the characterization of the phenotypic pattern of the occlusive disease and the severity of the limb ischemia. While we try to use things like glass and Wi-Fi, it never captures the totality of that. So that heterogeneity that's out there in the literature really, because you can look at a tibial, and if it's a robust tibial and you have the contralateral saphenous, you would assume, while that patient may be a worse phenotype, that the bypass should have a better than 25% chance of survival at 1 year. That being said, redo bypass in general obviously is a higher risk phenotype, and remediation strategies, which you showed several of, I think that's what's really interesting in this case, is all of the different decision algorithms. Is, are we ballooning? Are we cutting? Are we transposing? Are we changing our outflow? What is your threshold to reintervene if the patient doesn't have tissue loss or symptoms, and now you're using some duplex strategy? What are your duplex thresholds on a prosthetic, which nobody has any sort of defined criteria that is universally accepted. We generally use the Bandit criteria for vein bypasses, which is generally accepted in a lot more practices. But we know Dr. Bandic and others at USF have sort of they've been pioneers in bypass surveillance. And so curious to know at USF, what is the threshold for reintervention? Now, this patient, I would accept a much lower threshold because they've already failed and they've already undergone remediation. So any perturbation that you see post-op is going to give you a heightened awareness. But an a priori prosthetic bypass, is it drop an ABI by a certain proportion, or is it strictly a waveform change? Like how do you, what's your threshold, Jay, for a reintervention in general for a prosthetic versus a vein bypass?
Yeah, I know for vein bypasses, we monitor the velocities at the anastomotic sites. I think that criteria was developed by Dr. Bandic himself. It's like the 300 centimeter per second, or the velocity ratios of 3.5, as well as the if like the bypass flow is less than 40 centimeters per second as well. I know that in general we try to follow those guidelines for veins for PTFE as well. Although the numbers might be a little different, I think that we do take into consideration what the waveforms look like as well, and corroborating with a physical exam too. So if we notice that on prior exam, we have a multiphasic signal, now we have monophasic, I think that warrants an intervention too. So kind of a combination of what the literature says as well as what our exam finds as well.
Yeah, great. And one last question for you, Jay, is your decision to do lifelong suppressive antibiotics. Can you just walk me through that algorithm? Is that ID involvement? Is that something that you guys traditionally do?
Yeah, so that decision was made by the infectious disease team, which he was following long term back at when he was at Shands, and continued to follow up with ID here in Tampa as well. And it seems to be more led by the ID team rather than just our vascular team.
Thank you. I don't see any more questions. Great case.